Maddie Brown.
Maddie Brown. Yeah,
Thanks for being here. Thanks for chatting with me today.
Yeah, for sure.
Tell me a little bit about you growing up.
Um, well, I feel like I definitely was always gay. I feel like I went to a doctor's appointment when I was like in grade 8, and my doctor was like, "Do you like girls in your class more than boys?" And I was like, "No, maybe." And it kind of like from there, like every time I was encountered with the situation, people were like, "You're gay," from when I was very, very, very young. So I guess just like really gay.
Do doctors, is that a normal?
I don't know. I don't know. And again, I don't know if it was like teachers' concern or just like, like legitimate, not like family concern in a bad way, but just like family wanting me to know like this is okay, this is not a problem type of thing. But it was so funny, like would you go to a doctor's appointment now and have your doctor be like, so, are you gay?
Yeah, that's kind of what I was thinking.
Yeah, it's interesting though, but I enjoy it. I think I was again already aware of it, so I'm not saying they were wrong. It was just it was just an interesting approach.
So you're gay?
I would say so. Well, and my previous partner and I always talked about like bisexual versus bi-emotional, which I don't know if I've ever told you about in my random ramblings, but so like sex with a male partner is not like bad. It's not like the worst thing that's ever happened to me in my life. But the emotional part, there's like no connection there. I've never like met a guy that I've wanted to date or like see again or anything like that. It's more just like so I would say like when it's bisexual, it's like literally the sexual part only, but never any emotional attachment. Whereas with women, if we like make eye contact for longer than like 3 seconds, I assume we're like dating.
Did anything else influence you apart from your gayness?
Growing up,
Yeah.
I think I had like a lot of amazing male friends, like more male friends than female friends. Just connected with boys probably better than I did with girls growing up in terms of like a friendship capacity. So I was like really good friends with a lot of friends that I'm still friends with now, who were always like very protective of me and never, homophobic or anything like that. It was always like very accepting with the guys in my life, but I think I had a harder time with girls and kind of bullying and homophobia and stuff like that.
Interesting.
Yeah.
So how did that sort of impact you going forward? The whole thing, but how did you get to where you're at now?
So I went to nursing school after high school, and I think kind of like always my big premise in life has always been helping people. So always kind of even when I was younger, if I had my close guy friends who were like skateboarding and one of them got injured, they were at my house and I was like bandaging them up or doing like my little first aid projects. And I feel like when I was a kid too, all my like stuffed animals had like bandages all over them all the time. So like that type of thing I feel like has kind of always been a part of my life, the taking care of other people part, which led me into nursing. And I worked basically right away when I graduated. I worked with palliative patients, so patients in their last like days to weeks of life, and usually children, which is always like people are like, that is the most depressing thing I've ever heard. And then I probably work more with the adult population now, but still some pediatric palliative care as well.
That seems like going in the deep end.
Yeah, exactly. It's you know what? It's one of the underserviced areas in Canada. I think and I've said this so many times. I think that we are so comfortable talking about like everything except for death and dying in Canada. It's like a big celebration every time somebody has a baby or there's a birth announcement or a pregnancy announcement. But when we talk about death or palliative care or somebody being diagnosed with a terminal illness, people are like, oh, fuck, what do I say? Or how do I approach the situation? And even in nursing school, we had a mandatory rotation where you had to do maternity and there was no mandatory palliative care rotation, right? So it's like the beginning of life is this part you can't miss, but the end of life, you don't really, let's kind of just avoid that, which is kind of par for the course in Canadian culture where we've, kind of always had this like area where we don't want to discuss it. And I think that's where I try to do a lot of my education with telling people that it is okay to talk about and ask questions. And it's such a huge part of my day-to-day life. I mean, pretty much every time somebody's diagnosed with something terminal, I'm contacted in some way, shape or form because, they want my nursing advice. They want that family member or loved one to access cannabis as a medication through their illness, or just, different resources. They want, because they know I've gone through it with so many patients, where do I go for therapy? Where do I go to get some of my medications covered? That type of thing.
How many people have you seen die? Or, maybe
Yeah.
not been there, but in those last days?
Well, actually, it's funny that you say that. I've seen 49 people take their last breaths. So, been in the room, which people are like, how the fuck do you know that? My memory's really good for absolutely ridiculous things. I might walk into a room and forget why I walked in there, but I can remember all sorts of stuff from the past, almost word for word or number for number. And I can remember most lyrics if I hear songs and things like that. And all my old friends' phone numbers too from back in the day. 49 patients where I was in the room, whether it was because I was, there alone with them, they were dying at home, whether it was because I was working at the hospice and I knew the patient was close, so I went into the room proactively, or because family called me because they noticed a change and I get to the room and I'm like, yeah, they've got minutes or seconds left, so I've stayed. And it's the amount of people I've looked after is totally different. I mean, I've worked in facilities where there's a 10-bed hospice, and there's 10 new patients every month because it's a very high turnover rate. So if we're talking how many patients I've looked after that are palliative, hundreds, maybe thousands, but kind of been in the room or been right next to them, 49.
I don't think a lot of people can even imagine one. Maybe one or two, and your parents perhaps in your life.
Yeah, for sure.
Something like that. You're how old?
33.
And you've seen 49 people take their last breath.
Yeah. I've been nursing for 11 years. So almost 12 years in September, which is horrifying.
It'll be almost half your life soon.
Yeah. Ew.
Sorry. How do you think that's affected you? It has to have affected you, right?
You know what? I feel like the most important thing is that it gives you a lot of perspective. It gives you this kind of insight into what's really important, and not to downplay everybody else's, traumas or concerns or, issues. I'm not saying that just because you're not receiving palliative care, you have no right to go through a hard day, but it gives you so much perspective. Yes, going through fights with your friends sucks, but you have time. Losing a job sucks, but you have time. Ending a relationship sucks, but you have time. When your time is limited by an illness, you value it so much. You really spend time doing what you really, really, really want. And I think that allows me sometimes to write off things that maybe other people would spend a long time kind of lingering on or reminiscing on. And I feel there's pros and cons to that. But I feel that's kind of it.
Do you think there's been a negative way? I feel some of what you were saying there could go negative, but most of that's a positive outlook, I think, of realizing we only have so much time.
Yeah.
And do you think there's been a negative side of it?
I feel apart from me, when I have a headache, I'm it's my last headache ever because this is brain cancer. But I feel realistically, some of the negatives, it's very emotionally heavy, right? If you, I used to work 12-hour hospice shifts, so I could have 3 people die in one shift, right? Where I'm walking into the room and thinking to myself, okay, this is this family member and this is their daughter's name, and you're trying to get names right and make sure that you're calling the funeral homes and all of that stuff. So it can be so heavy. And of course, I was honestly just explaining this to my friend Michaela. So you can have somebody who's 100 who's dying, and it's sad for the family and friends and everybody, but that is kind of the natural process of things. After 100 years, if your heart is nah, fuck it, well then that's how it is. And of course it's sad, but you're not sitting there saying, how did this happen? When you have a 5 or a 6-year-old or a 20-year-old, that is not the natural order of things. Your heart should not be stopping at 5 or 10 or 20 years old. So I think that can be so heavy that you have to have kind of coping mechanisms or strategies in place where you can meet up with your hospice nurse or support worker or social work staff and go for, a bite to eat or have a drink and decompress and talk about things that we all understand and that we all kind of have in common. Where, we're not like going to work every day and fixing a vacuum cleaner or something. And again, I'm not discounting people who work on vacuums. That's extremely important. I love my vacuum. It's probably my best friend. But if you fuck up a vacuum, you fuck up a vacuum. It's so significant, the things that we're doing, that I think there definitely has to be that kind of like downtime or decompression time where you're either connecting with people or doing lots of kind of personal self-care. And I'm getting better at that, but I'm not fantastic at it. But I'm better at it, maybe.
That's fair. That's fair. You said it's an underserved part of the system in Ottawa.
Yes.
Canada. Canada, excuse me. Because you're talking about, obviously going out with these people, like, what is the situation really? Like, tell people, because people don't know. I'm sure people don't know, and unless you have to interact with those things, which you never think you will.
Right.
So what is the situation
with palliative care? So I think just further to what I was saying about people not really wanting to talk about death and dying, that's just a big part of kind of the taboo culture of palliative care and it not getting enough attention. But secondary to that, a lot of places, like a lot of hospices, whether they're adult or children's hospices, are considered charities, meaning they don't get funded the same way that a hospital might. They have to fundraise for certain parts of it, and that's great. We love the fundraising aspect of hospice, and there's a lot of community involvement, which is so important with palliative care as well. But, again, maternity care is fully funded, right? When you go to the hospital to have your baby, you're not, the nurses who work in that area are not fundraising for the other kind of funding of their allowance, I guess, or whatever, their budget per year. So that's a really kind of downside to palliative care, because it's just something that doesn't allow it to have the same kind of financial benefits as other areas. But again, we're getting better with funding different palliative initiatives in Canada in general. And I mean, hospices all over Canada are doing amazing work at kind of being involved and again, community oriented. The hospice that I work at is great, and it's like fantastic for all of its community support that it does, and really good care provision. Families come to us all the time talking about all sorts of different positives that they have about their experience in hospice. So I think just, again, normalizing talking about death and dying is really the kind of crucial thing.
And it must be like, there must be a pretty good turnover rate too of people, I'm sure, because it's like you said, it's heavy. And sorry, in terms of the staff, not in terms of the people coming to the palliative care, in terms of the staff.
Yeah, for sure. Again, and I think like that isn't like that isn't like related to even hospice. I just think healthcare right now, the turnover rate, like in all areas of healthcare, is just absolutely huge in regards to the need for nurses, the nurses who aren't willing to work, the nurses who are burnt out from COVID, depending on what you were doing during those years. So it's just a tricky area in general to work in, and one that you're really only working in healthcare if you want to be. Like, you have to really want to go in every day and deal with terminal patients or wounds or blood or whatever it is. Like, no one's just like, I might try that out. You have to be like, this is what I want to do. So I think that there's just a big need for healthcare in general to kind of have a few more people involved, I should say.
What do we do?
I guess, I don't know. I'm not as kind of well informed on the political side right now. But we just need a huge amount of healthcare workers. We need doctors. We need family doctors. We need family doctors in rural or hard to reach areas. There's Indigenous communities all over Canada that don't have a walk-in clinic or a hospital with normal functional hours. So that kind of issue of lack of service is huge. And I think, again, all we can really do is educate people about what's going on in Canada. You know, we have baby boomer population who are aging and ending up in hospital and in care, and that number is just going to get higher and higher, and we have less and less kind of staff able to deal with that. We have longer wait times for things like nursing homes and retirement homes. So we just need more people aware of that and then considering getting involved in that line of work. I mean, you have to be trained to work in these areas, right? So then you have to have that, you know, whatever makes it desirable for people to go into those careers.
So let's pivot a little bit. Something that you talked about a bit before, the access to medical cannabis.
Yes.
So how did you get involved with that aspect of it?
Okay, so I was always a user of cannabis long before legalization. I was never really big into alcohol, even like, you know, in the experimental teenage years and growing up, it was more just cannabis for me. And I didn't realize it then, but it was acting very much as a medication for me. You know, I wasn't smoking and then being or feeling super stoned. I was smoking and feeling calm and at ease, and that like I had an appetite and I could sleep finally. So I think, you know, I was using it far more than a lot of my friends, and probably far more than my, you know, family and friends were wanting me to. But when I got older and started in nursing school and started learning about the differences in the different strains of cannabis and the CBD THC aspect of things, it became more clear that I could and should use it as a medication. So I've had my prescription for cannabis for almost 10 years now, long before legalization. And I think that that's something that's really been able to help me. It helps me with, like I said, kind of appetite and sleep and mood regulation, where I've tried so many other different medications and therapies and treatments with not quite the same success rate. And not that I don't take pharmaceuticals now and don't do my kind of therapy sessions now, but it's just something that's always been in my repertoire of things that help me out. So when I got into nursing and cannabis started to be used so frequently because of my line of work, right? It's palliative care, so everybody wants to access cannabis medically. I started working in cannabis clinics as their nurse educator. Then I started developing my own cannabis programs and teaching them across Canada, actually. And you know, I was on programs like White Coat Black Art and different CBC segments just regarding cannabis and legalization and CBD and what it meant for Canadians. So I think it's still kind of in the end has to do with palliative care, because really I got into the medical side of it because so many of those palliative patients were wanting to access it.
How far do you, I mean, it's only been illegal for 6 years now.
Yeah.
Right, 2018. But how far do you think it's already come in that time, and like where is that space moving to?
So again, I feel like that it's come a long way in certain ways. I think it was like not necessarily the best rollout in the history of the world. But you know, again, bottom line, it is legal. There's a lot of pressure and kind of onus removed from people and businesses when they now have people either using cannabis or accessing cannabis. I think it was something that was highly, that was used a lot on the gray or black side of things anyway. So you kind of have this government that's like, well, we kind of want to reap these financial benefits, so we're going to legalize it and tax it, which again, there's so many pros and cons, right? I don't necessarily agree with the rollout, but it is legal. I don't have to worry about, if my friends are out and they're having drinks at a restaurant, well, I can go outside, and as long as I'm 9 meters from the door, I can smoke a joint and not have to stress about a legal charge or any legal implications or, that type of thing, which, that part's beneficial for sure. I think we have a bit of work to do still with clearing some criminal records from people in Canada who have long-standing cannabis charges. But I think it's more pros than cons, I think.
And do you think overall the effect because there were a lot of people before the legalization who thought this is going to be very detrimental to society.
Right.
Do you think it's been a pro or a con overall?
I think it's been a pro. Again, I I think for the most part, in most countries where it's been trialed, any like decriminalization or legalization of drugs has resulted in, less charges, less rates of family separation. There's less people who are stealing to support their addictions or drug habits, whatever they may be. There's less people who are purchasing cannabis from illicit sources. And again, like there are people who will always buy it from non-government providers. But for people who are really, really medically fragile, well, not having to wait months and months to get a doctor's appointment to get your prescription to go use that product, it's really nice that they can walk into a store, and if that government product says 10 milligrams of CBD, that is actually what they're getting, and having that medical confidence for users, I think, is really big. If you're using recreationally just for fun, well, kind of go for it. If you use too much or whatever, that's similar to alcohol, right? Everybody drinks too much sometimes. So if you use too much cannabis, it's not the end of the world. But when we're talking medically, it's different. And that's where I think people have that reassurance that they are buying those products, when they're buying those products from the government, that they're really getting what the package says. And that's something that the black market, has a hard time with. If you buy a pack of edibles in the black market, it's like, the bag says 100 milligrams and the person who brings it to you is like, but it's actually 300 milligrams, and it says it's chocolate, but it's gummies, and it's banana gummies, but it's actually cherry blasters. And you're like, okay. Like, so there's that kind of like unreliability aspect where people who are using medically really want that like consistency. They want to take it like a capsule the way they do their other medications. They don't want to take something that says banana flavored when it's actually a chocolate, right? It just doesn't have that it doesn't like instill confidence, I guess, is what I should say.
Do you think that this is a path towards, if not legalizing, decriminalizing other drugs, maybe all drugs? And if that's the case, is that a bad thing?
No, so I don't think decriminalizing drugs will ever be bad. I think, again, if you like look at actual statistical like data on harm reduction sites and decriminalization, it just has better outcomes overall. And again, a lot of people's concern is like, I don't want my tax dollars to go to a safe injection site. Okay, well, if there's no safe injection site, well, that person will OD, and the ambulance coming and then them being admitted to hospital is actually going to cost you far more in terms of your taxpayer money. So if you really want to save money, you should probably vote for the sites in general, right? But I think that cannabis has its kind of like way of integrating into all of that system as well. But I don't know, it's really tricky. It's really tricky with the funding of all of that stuff. I think more so than it being a negative thing, it's a positive thing. I think that people will use drugs regardless of what society tries to do. You can say, let's put in 20 more rehab centers. Well, no one gives a shit if there's a rehab center there if they don't want to go to rehab, right? You can't force somebody to go to rehab. So statistics say that harm reduction is a better approach to actually getting people clean and sober than simply criminalizing drugs. Or like if you find or have a person who's unhoused, who's on the street, who's overdosing, are we really going to first bring them to the hospital for that huge series of taxpayer dollar events and then bring them to jail to process like a small charge for heroin when they don't even have a health card or a SIN number that they can kind of reference? Like, it's just this kind of waste of resources where it doesn't matter that that happens, because when they leave jail, they're going to go use anyway. That's just how the unfortunately addiction works. And addiction's terrible. It's just like any other disease, right? I work with cancer patients all the time who somebody with brain cancer, right, who punches me in the face when I'm providing care to them. No one would be like, oh my God, like press charges, like that's appalling. They'd be like, well, they have brain cancer. They aren't aware of what they're doing, or they're aggressive because of the brain cancer. If you got punched in the face by somebody who's perhaps homeless or unhoused on the street and they're an addict, you'd have everybody saying, press charges, fuck that. But their brain also doesn't work the way anybody's brain works when you're sick. So I think addiction is so tricky, and whatever we can do to support people who are going through addiction is probably the best, I think, for everyone financially and health-wise. I don't think criminalizing drugs is going to be beneficial for addicts, and I definitely don't think that reducing or eliminating harm reduction sites will be helpful for anyone either, especially if we're talking financially.
Yeah, no, that's incredibly profound, honestly, because you're exactly right. Wow.
It's always the cancer perspectives that gets people, right? You're like, fuck, yeah, no, that's true. I would never like fault somebody with brain cancer for doing something stupid, but even like a mental health crisis, you have somebody who's bipolar, who's blowing up at you and telling you all these terrible things, and you're like, fuck that person, I'm writing them off, what a terrible person. Well, if somebody with brain cancer said that to you, you would never ever respond like that. You'd be like, oh, poor thing, what a sin, right? And that's just the way it is.
Tell me about some of the good stories from in terms, some of the people who it was incredible.
Yeah, for sure. So I feel like I'll talk about two patients. So one of them was a wedding that we did at the hospice, a woman who was really young who had just been diagnosed with cancer. She had left an abusive relationship and had met like the love of her life 6 months later. And then 6 months after that was diagnosed with terminal cancer, as you do, right? So she knew she was dying, he knew she was dying, but they still just wanted to get married. So like I can't even explain like getting a woman into a wedding dress is never a joyous task, let me tell you. When they can't move and they're in a hospital bed, it's we were like the amount of like lace and just like material, we were like, oh my God. And she's barely able to move. We somehow got her into the dress, into her wheelchair, and just like I'll never forget like wheeling her down the aisle with all her family there. And it was hospice is I always say it's a beautiful place where very sad things happen, or it's a very sad place where very beautiful things happen. So it's kind of like pros and cons, like everything in life. That's going to be my next tattoo. Pros and cons somewhere on my free space that still exists.
What's the second one?
The second what?
Second story. You said you had two.
Oh, yes. Oh, yeah. Okay, so that was one of my patients. And then my friend Emily, who just died at the end of March, so just literally a month ago. So she had cervical cancer and, had been going to the doctor for years complaining of, pain and bloating and bleeding and all sorts of stuff. And it was kind of, brushed off or disregarded by the time she had the attention she needed. They were like, you're full of cancer, and she was 32, right? And she was diagnosed in April 2023, and she was dead in March 2024. So it's like 11 months, and she's my age, right? We went to school together from grade 9 onwards, and we've been friends for 20 years. So, and I looked after her for the last week of her life when she was at home with her mom and her brother and some of our friends. And you have this like, you go through your career looking after tons of people who are dying, but then you're like faced with a really close friend who's dying, and you're supposed to kind of like unbiasedly or unemotionally provide care, which, I was happy to do, but it gets harder and harder, right? So, when you're looking after somebody who you've never met before and they look really sick, it's terrible. And, you never want to see somebody look sick, but when you've known them before as well, and then you see them after they're sick, it's so shocking. And she got so sick so fast. She was so young, and I think she just deserved so much more time. I think her mom and some of her friends and I are going to do lots in terms of cervical cancer and ovarian cancer advocacy. Like my previous partner's wife died of ovarian cancer as well. And again, an area that was just not addressed as soon as it should have been. And then my partner had to go through this traumatic experience with her partner at the time. So, this area of women's health is just so underfunded. It's under-researched. I just think that talking about Emily and having women just advocate for themselves, like, when something's fucked in your body. Emily had had her period for 20 years at that point. Like, when something's like not the way it used to be. So I think just doing advocacy for women's health in general, for people who are any type of minority group, whether it's Indigenous people, trans people, gay people, anybody who's experiencing kind of that that minority side of healthcare, it's really tricky. You don't want to be in the system if you're part of a group of people that are underserviced, I guess, and not always respected within that healthcare system. And again, it's not just like one person or one institution who's like not treating those people well. I just mean societally, that's how we've always been, right? It's just we have these ways that we're trying to unlearn and trying to be better about, but we still have history that we need to acknowledge as Canadians too that's really damaging. So
yeah, I was going to ask, you sort of touched on it, but why is the health system, and I guess the greater systems in general, but why is it like that? Like, why can a doctor not take her seriously when she comes to them and says, hey, something's really wrong here, and they're just like, you're fine.
Yeah.
How can the system be like that?
No, for sure. And I mean, again, and I'm certainly not discounting, again, I'm always like just clarifying. I love doctors. I work with some amazing doctors, and you can have mistakes are always made in healthcare. Of course, you can miss things. You can go above and beyond to investigate something that turns out to be nothing. And then the next person that comes in, you're like, it's probably nothing. And depending on what type of advocacy you have in place for yourself, like you just might slip through the cracks. So, if your doctor is really, really kind of attentive to patient needs, and I'm not saying that not all of them are, they all love their patients. To work in that field, you have to, but you can miss things, you can assume things. I do it all the time. Like, no one's perfect, but I think a lot of the time, for family doctors at least, like one of their biggest jobs is to act like a liaison. So like you go to your family doctor and say, I think I have a lump in my breast. Well, then they send you off for breast screening somewhere else, right? So I'm not saying every woman that comes in or every person that comes in with menstrual pain or really bad cramping or bleeding, not all of them will be like, this sounds like cancer or whatever, but we can do certain things to investigate a little further. We can advocate for ourselves or other women to have things like ultrasounds or more regular pap smears, which is changing too. Like, it used to be every year, and now I think it's every 3 years. Don't quote me on that for pap smears. But again, it just seems like one of those things that we should do more regularly as opposed to less regularly. And even so HPV wise, right? So HPV, unless you were born before, I think it's 1992, you didn't have the HPV vaccine given to you. And now if you want it, it's about $1,000. So 99.9% of cervical cancer is from HPV. So, you're like, okay, so people can't afford $1,000 for injection, so they're not going to get it. So you're going to have these men and women end up in the hospital with various forms of HPV-derived cancers, and that's going to, again, cost us so much more than $1,000 per person. And if you're in school right now, well, in grade 8, you get that shot. It's covered. But if you were born before 92, then it's not, and you didn't have that kind of offered to you in high school. So, or if you did, your parents were like medical people who knew that it was something you should have. So even that, in the sense of education around HPV, I tell so many of my friends that, and they're like, wait, what? I didn't know I was supposed to have that. There's no way I've had it. What's it called? Like, it's called Gardasil. So, if you're in that age bracket, go to your doctor, go to your nurse practitioner, go to your Shoppers Drug Mart and say, is this on my, medication history that I've had? And it's worth the expense. And if you do have insurance, of course, there's going to be portions of it that are covered or maybe full coverage, but a lot of people don't have insurance or benefits or the ability to be like, sure, I'll get $1,000 vaccine this month. Like, who needs groceries, right? So there's so many things in our healthcare system that are amazing, and like every country, there's so many things that are so tricky, right?
It sounds like it's resources. Ultimately, like most of these problems, there's more resources required.
Yeah, and especially I want to like specifically say, especially in Indigenous communities, which are often rural and hard to access. It's not fair that because they live in an area that's hard to access, because of weather or because of vehicles or because of employees, that they don't get access to the same type of services at the same rate or in the same kind of time frame. So I think that's something we really need to improve on as well. Our hospitals are not fantastic right now, but there are hospitals in Indigenous communities that literally don't have staff. So I think, resource allocation needs to kind of be done in that regard as well, with who really needs help. And I think that that's a big area that needs it.
Wow. Yeah. I'm excuse me.
I can't believe he's been quiet this whole time.
He's been a good
shocking.
boy. He's been a good boy. Sorry, I have like a cough stuck in my throat. So I feel like just from what we've talked about, the perspective you have on life is different than a lot of people, and we've touched on that a little bit, but I want to sort of circle back and just ask, like, what would you tell people watching this? Like, what would you want them to know from what you've seen? What do you think would help the world? Like, what do you want to tell them?
What do I think would help the world would be like putting aerosolized CBD in like all government and hospital establishments for the masses. And then I think the second thing is just to not take advantage of time. Time is one of those things that I think we kind of lose sight of sometimes. And again, when you work in palliative care, it's a little harder to lose sight of. You literally watch time like disappear from people. So you end up with a little bit more insight in regards to what's really important, what's really, really meaningful in life. I try my best to not kind of lend too much feeling to things that are in the past. And like, as I say that, I'm like, oh my God, there's gonna be so many people that laugh hysterically at that because I like live in the past, but I'm trying, is what my operative word is there. I am trying to kind of, especially with Emily's death, allow things to really be put in perspective, because I've, gone through a lot in the past few months. And I think with, Emily's death, not like what else is like, who cares about all the other stuff? She was, a close friend and somebody who deserved so much more time. And if it had happened to me, then nothing that I'm even discussing now would matter, right? The perspective is all in that. And the unfortunate thing about cancer, Canadian Cancer Society says 1 in 2 Canadians now will be affected by cancer in their lifetime. Not necessarily that they'll die, but just that they'll be affected. So it's something that will affect most people that we know. So, just trying to enjoy every moment. You could have a fantastic day today and tomorrow be told that you have terminal cancer. And that's why people are like, and I am unfollowing Maddie Brown. I do not want to hear that. But I think, you can unfollow me. Absolutely do it. People do it all the time. But you don't have to ignore the death and dying because you're unfollowing. You can still be awkward about it and not want to think about it and not want to like do advanced planning, like think about your will and think about who you would leave things to if you were diagnosed with something tomorrow, or were in a car accident tomorrow and you died, and that's just, I guess, joyous parts of being a palliative care nurse, that things you consider, but things that are important that, again, we just don't talk about. You have every step of a baby shower planned, and we will never talk about death.
How do we change that? I think that's something that, how do we have more of a realistic conversation? Like, because it's something people are scared of. Like, yeah. I think that's ultimately why there's not enough. And how do we either undo the stigma around it or face the fear of our own mortality? What do you think?
I feel like education and talking about it, like I try to post as often as I can on my social media about death and dying, about talking about it, about normalizing it, about saying to people, if you have questions about it, come talk to me. If you're a nursing student and you want to join me at a palliative home visit one day, I will bring you and talk to you and teach you everything that you could possibly want to know. I think a big part of palliative care is teaching. Like, you're teaching the family about what to expect, about why their respirations are slowing, about why their heart rate's increasing, about why their extremities are cold or purple, or why they're having a seizure. So you're doing so much teaching and so much emotional support. That's really palliative care. We're not doing surgeries and invasive procedures and CPR. We're helping people die comfortably as best we can. And I think that that's one of those things that you just you do what you can to make people comfortable, and it gives you so much insight into what you do the next day. I think that's the big thing, is perspective, teaching, keeping people aware that like the only commonalities we have in life are literally being born and dying. Everything else is different, but everybody kind of will have those two experiences. In terms of life, you might not have the same experiences as anybody else in the world, but those two, we all got it, and we're totally cool talking about one, and the other one is like, no.
Would you consider, because you do a lot, would you consider doing, like, I don't know if advocacy is the right word, but essentially doing what you do with the medical cannabis stuff with death?
So like that's an interesting question. I think like so like a death doula is like a term that's being used a lot now. So similar to like how you have a doula when you're having a child. So I think again, somebody to help you navigate the dying process, even just to teach you like the not so medical things like mouth care, right? So when people are dying, they often breathe with their mouth open, and families are like, how? Their mouth looks so dry, what do you do? So just doing the teaching about putting coconut oil in their mouth and using little, like they're called sponges, or I can't remember the exact term, but they're basically like a tiny little sponge on a stick where I can dip it in coconut oil and soda water so that there's a really small amount of moisture on it. You're not at risk to choke, but I'm, moisturizing the inside of your mouth and around your teeth where it gets so uncomfortable. And families are like, I would have never known, what to do. And again, not that I'm like some sort of genius who invented these things. It's just learning in palliative care, right? And I learned from some really, really good doctors and nurses who basically kind of taught me everything. But you also have to want to do palliative care. You can't be like, oh, I think I'll apply at the hospice. You have to be like, I'm okay with this.
What do you think Emily would want to tell people?
Emily, she would tell people, so Easter was her favorite holiday. I feel like Emily would tell people that all the time, but Easter especially is like a chance to like restart, renew. The plants are coming out, the winter thaw is gone. I think she would just say, like, regardless of the season, but also especially during Easter, to just like give yourself a chance to start new. I think she would tell all of the women in her life to advocate for themselves in the medical system. I think she'd tell her mom she loves her, and she'd probably hug her cat because she was a cat person, which was her only flaw. I know, she was a gem. She was if I had a picture of her to hold up, I would, but she was really, really, really just a gem, and she deserved a lot more than 33 years,
Is there anything else you want to say?
I always do like to say that I'm thankful and appreciative to be standing on traditional Indigenous territory. I'm always happy to help anybody that needs it, whether it's on social media or through text or through email, who does need help with navigating either the cannabis system or the death and dying kind of process or palliative care system. I think it's just an area that should be funded. Both of the areas should have funding for different people to learn about both of those things. And so I think I'll always be somebody who tries to provide that at little to no cost if possible. I'm like the worst business person ever in that regard. But that's okay. I think karma, right? Life is very karmatically oriented. So you treat people a certain way and you expect certain things. And if you do it the wrong way, then karma will come find you.
Maddie, thanks for talking to me.